Welcome to today's session entitled Hope and Help for Those Facing Alzheimer's Disease, New Developments in Research, Care, Support, and Prevention. Before we get started, I would like to go over a few items so you know how to participate in today's event. When you join today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you can do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. And now I'd like to introduce John Feather, CEO of Grantmakers and Aging and moderator for today's webinar. John?
Thank you, Tracy. I'm delighted that so many of you have joined us today. Before we get started, I want to thank our co-sponsor, Bader Philanthropies, who has a long-standing interest in Alzheimer's disease, and we thank them for their support. We also want to thank the John A. Hartford Foundation, whose support throughout the year allows us to provide this webinar free of charge. By 2050, more than 28 million baby boomers are expected to develop dementia, the only leading cause of death among the top 10 in the US that cannot be prevented, cured, or even slowed. Still, there are reasons to be optimistic. There's unprecedented momentum in Alzheimer's research, and innovations in care are enabling more people to live their best possible life with the disease. Today, we're joined by leaders from the Alzheimer's Association to share how scientists are making progress towards the national goal of treating and preventing Alzheimer's disease by 2025, and how healthcare professionals and others are becoming better equipped to diagnose and support those living with the disease and those who care for them. With us today are Dr. Heather Snyder, the Senior Director of Medical and Scientific Operations at the Alzheimer's Association. She manages the Association's International Research Grant Program, a mechanism through which the association funds research applications. She's also responsible for a number of specific research initiatives to better understand the underlying biology of Alzheimer's and manages a collaborative project with the National Institute on Aging at the National Institutes of Health to develop an international Alzheimer's disease research portfolio. Dr. Joanne Pike is the Chief Programs Officer at the Alzheimer's Association. Her work with the association includes the care and support services offered across the organization to those affected by the disease, health system outreach and quality improvement initiatives, long-term care initiatives focused on person-centered care delivery models, and growth strategies for reaching more individuals through quality improvement, education, and supportive programs and services. We're delighted to have both of you with us. As Tracy mentioned, those of you in the audience can enter your questions in writing at any time. Just open the questions box in your control panel, and I'll be asking the questions of our speakers as we come to the end of their presentations. So Heather, we're going to start with you. So get started with us now about what have we learned and what are we optimistic about in terms of Alzheimer's disease?
Great. Thank you so much, John, and thank you very much to Grantmakers and Aging and to today's sponsors, the John A. Hartford Foundation and the Bader Philanthropies, for the opportunity to join all of you here today. We're going to talk a little bit about Alzheimer's disease biology, what we understand, the impact it's having on an individual and on our society at large. The progress in research, how has our understanding of the disease changed, and what does this mean for the next generation of clinical trials and potential interventions? Our expanded reach for care and support services to help all of those that are affected by Alzheimer's and related dementia, and the coming soon dementia care recommendations, and then how all of us can be a part of the fight against Alzheimer's and a part of the solution for tomorrow. A little bit about the Alzheimer's Association. We have a mission to eliminate Alzheimer's through the advancement of research, provide and enhance care and support services for all of those affected, and reduce risk of dementia through brain health. And we're going to touch on each aspect of our mission through the work that's happening in the broader field and in the broader community. So we'll start off our session, our time together today, by talking about where we are in research and to set the stage about the advances that we've seen in research. I also want to talk a little bit about the role of the Alzheimer's Association, as that will come up in some of what we'll talk about. The association is the leading nonprofit funder in Alzheimer's and dementia research in the world. We have over 110 million actively at work in 18 countries, and this makes up about 400 or so ongoing research projects. We don't know where the next great understanding of the disease or advancement will come from, and we want to make sure that at any given time we are advancing the best science going forward to answer those complex questions. Thomson Reuters Insights tool rates the Alzheimer's Association as the highest impact nonprofit, and actually the third overall, only behind the US government, NIH, and the National Chinese Foundation, which is the Chinese government. The Alzheimer's Association International Conference, or AAIC, is the leading convening opportunity for dementia scientists in the world. Brings together over 6,000 scientists each year from over 60 countries to share the latest of what's happening in the field and where we need to go as a community, and where the research needs to go next to ultimately reach our goal of a world without Alzheimer's. We also published the leading journal in clinical neurology. It's the top disease-specific journal in clinical neurology, Alzheimer's and Dementia. And all of these are going to come up in some of our discussion today. In the United States, in 2011, there was the passage of the National Alzheimer's Project Act, or NAPA. And this resulted in the first national plan to address Alzheimer's. This raised Alzheimer's disease to a national priority, that we had to get ahead of this disease and we had to make a change to address this disease and related dementias. Since the passage of the plan, we've seen over $800 million in increased funding for Alzheimer's research, which is really phenomenal over the last 4 years to see these kinds of increases. And currently, there's an additional $414 million pending in the budget in discussion in Washington. All of this is towards the larger goal that's in the national plan to prevent and effectively treat Alzheimer's by 2025. That's not that far away, but where are we in terms of making progress? We're optimistic that we're still on track for this, and I hope by the time of at the end of our time together, you have some optimism about where the field is going as well. And it's essential that we continue to have that optimism, and we continue to make those investments in Alzheimer's research. When we look at the number of people that are affected by Alzheimer's, over 5.5 million Americans, not to mention the cost to the family, but also to our society at large. As John mentioned, it is the 6th leading cause of death and the only cause of death in the top 10 that we currently don't have a way to prevent, cure, or slow. And in addition to the individuals living with this disease, there's the more than 15 million Americans that are providing care and support for someone with Alzheimer's or another dementia. But what we are also seeing is that awareness of Alzheimer's is continuing to grow. We had the Still Alice movie just 2 years ago that saw a significant increase in Alzheimer's disease and asking questions and an understanding about what's needed for the family, seeking additional resources. More recently, in the past 2 weeks, we saw the tremendous commitment by Bill Gates to invest in research and move us forward at an accelerated pace. So when we think about the different terms that we often hear, dementia and Alzheimer's disease, what do those mean? And a good way to think about it is dementia is really that umbrella term that's used to describe a number of different diseases. Alzheimer's disease is the most common cause of dementia, making up anywhere from 50 to 75% of all individuals that are living with dementia. But there are other kinds of dementia, vascular, Lewy body, frontal temporal. And all of them, while there are some commonalities, there are also some differences. Understanding those differences is a big area of research today. When we think about Alzheimer's disease, what is it? It is a degenerative brain disease, as I said, the most common form of dementia. It is progressive, with the idea that actually the underlying biology is changing a decade or more before an individual has the clinical symptoms. And we'll come back to this in a couple of minutes. It is causes of memory loss and a decline in an individual's cognitive ability. So that is the memory, reasoning, and thinking of an individual that will affect their daily activities. It is fatal. Ultimately, we think about that you forget your loved one, or you forget how to get to the grocery store or get back home. But ultimately, you forget what your tongue is, how to swallow, and how to breathe. When you look inside the brains of an individual with Alzheimer's, you see something that looks a little bit like this. The large clumps of proteins that you can see pictured here that are named plaques are between the brain cells. The primary component of plaques is a protein known as beta amyloid. So we hear a lot about beta amyloid as a potential target for a therapy intervention or as a possible way to detect brain changes in an individual with Alzheimer's. Inside the brain cells, you see what is pictured here as tangles or neurofibrillary tangles. And the primary component of tangles is a protein known as tau. More recently, we've been seeing clinical trials emerge that's targeting the tau protein, as well as possible tools to detect the tau in living individuals. When you look on a larger scale of what might be happening in the brain, you see something like this. So the different colors actually represent where you see the brain changes associated with Alzheimer's. You see the buildup of the beta amyloid plaques, the buildup of the tau tangles, and also you see cells that are dying, and so you see a smaller volume of the brain, or what we call atrophy, and you can see that depicted here in green. Understanding all of these biological changes is incredibly important as we think about what happens over time. What are the changes, and what should we be intervening with a potential therapy? In the last decade, we've made significant advances in our understanding of the disease to know that the underlying biology is happening over time. Over 2 decades before an individual has the clinical symptoms that you see here as depicted as dementia, we will have the biological changes. And this presents an opportunity that if we can detect an individual with the biological changes, we can intervene at that time point to stop or slow the progression of the disease. So picturing it in another way, you can see Alzheimer's disease is a continuum, not unlike how we think of heart disease, right? So you don't just wake up and have a heart attack or a stroke. There's actually a change in the underlying biology in an individual over time, where you'll have an advance cerebrovascular disease, where you see changes in blood pressure or cholesterol that can be measured in a physician's office. And it's that same kind of idea with Alzheimer's disease. What we've traditionally thought of as Alzheimer's is really Alzheimer's dementia, where an individual have more significant deficits in their memory, their thinking and reasoning that will affect their daily life. There's an earlier window of time where someone might have early memory changes or mild cognitive impairment due to Alzheimer's. And this could affect their daily life, but there might be also activities that they can continue to do independently as well. And then again, still very much in the research space, but continuing to gain momentum, is this idea of preclinical Alzheimer's disease, where an individual will have the biological changes that you can detect either with looking in cerebrospinal fluid, that's the fluid that our brains are bathed in, looking in blood, looking in the eye as a window into what might be happening in the brain, or different imaging technologies like MRI or CT scans that we see within the doctor's office today. So just to give you a visual of what this might look like in a living person, this just shows you a picture of biological changes that are associated with Alzheimer's, and specifically detecting the buildup of the beta amyloid protein. So you can see on the top here, this is an individual with normal aging, changes in their brain, and you can see, you don't see that bright color reflected. The individual on the bottom has Alzheimer's disease, and the bright colors are reflective of the buildup of the beta amyloid protein in those individuals. But how do we get to the point of understanding that these changes are happening over time and that there's a continuum that's going on in an individual? These biomarkers, such as PET imaging, has advanced us to that place where we now can look in living individuals over time and see those changes. So how do these advances happen in the field, and what's their overall impact, in addition just to our understanding of the disease? In 2001, there was a researcher at the University of Pittsburgh, Dr. Bill Klunk, who had an idea that in the animal models of Alzheimer's, he could image and see the biological changes associated with Alzheimer's disease. He received funding from the association to do just that, and to design and create a tool that would allow in a living animal to detect the changes associated with Alzheimer's. He was very successful in this, and you can see this is a picture from the University of Pittsburgh team, where you can see the significant changes between Alzheimer's disease and an individual without Alzheimer's disease. In 2006, there was the launch of a large study called the Alzheimer's Disease Neuroimaging Initiative. This was primarily funded by the National Institutes of Health, with the idea that it will follow huge numbers of people over a long period of time and collect all sorts of information. It had actually been originally funded in 2004, but when amyloid imaging, or the ability to detect amyloid in a living person, wasn't yet ready for clinical trials. So in 2006, with funding from the Alzheimer's Association, this tool was added to the ADNI study, the Alzheimer's disease neuroimaging study, as well as to many other studies that were ongoing. And it was actually from these studies that we began to understand that about 30% of people with a diagnosis of Alzheimer's don't have the biological changes associated with the disease. And it also opened up the idea that there were individuals that had the biological changes that didn't yet have the symptoms associated with Alzheimer's. All of this evidence continued to compile and led to the understanding that Alzheimer's disease is a continuum, that the underlying biology is changing a decade or more. The Alzheimer's Association partnered with the National Institute on Aging to publish the revised diagnostic guidelines, and that it really set forth this parameter that there was preclinical Alzheimer's, that we could identify people with the biological changes without the clinical symptoms and intervene at that time point to stop or slow the progression of the disease. This opened up the window to possible prevention of Alzheimer's disease. Again, very much like how we talk about heart disease, the idea that you can detect someone that has elevated cholesterol or high blood pressure or other biological changes that make them at an increased risk in later life for heart attack and stroke, intervene at that time point, medication or lifestyle, and change the trajectory for heart attack and stroke in later life. Just a year after the publication of the revised guidelines, the FDA, the Food and Drug Administration, approved the first agent for clinical use to detect beta amyloid in a living person. It's not a diagnostic for Alzheimer's, it's what we call a rule-out diagnostic. As I mentioned, there's about 30% of people that have elevated amyloid that don't have the biological changes or the clinical changes associated with Alzheimer's. And so if you have amyloid in your brain and you have memory changes, it increases the certainty that it's due to Alzheimer's disease. If you're having memory changes, but you don't have amyloid, the memory changes are due to another cause. There's another reason for the individual to have those memory changes. With this tool in hand, the Alzheimer's Association partnered with the Society for Nuclear Medicine and Molecular Imaging to say, who should use this tool? Who should have beta amyloid imaging during their diagnostic workup? And it was actually a relatively small number of individuals, those that were under the age of 65, those that had an atypical presentation in terms of how they presented to their physician with their symptoms to help increase the certainty of their diagnosis. At this time, this is not covered by the Centers for Medicare and Medicaid Services. However, what is covered is something called coverage with evidence development. The Alzheimer's Association partnered with the American College of Radiology and a number of leading experts in the field to launch the IDEAS study, the Imaging Dementia Evidence for Amyloid Scanning, which actually is enrolling over 20,000 individuals that meet those very specific requirements or criteria that they would benefit, their diagnostic workup will benefit from the use of this beta amyloid imaging tool. This is the largest clinical trial in Alzheimer's disease in the United States to date, and preliminary studies suggest that by increasing the certainty of a diagnosis for an individual that might not be as clear-cut, that actually it benefits their care and their care management long-term. This trial still is ongoing, however, and so we look forward to seeing the results, as that's really important in thinking about people that are already experiencing the memory changes. How can we make sure that we're providing them the best care and the best support going forward? As I mentioned, this understanding of Alzheimer's disease is a continuum, that there were individuals that we could detect at an earlier stage with the biological changes without the memory changes, opens up the window for us to move the needle back in time and us to think about possible prevention. Because if we can delay the onset of Alzheimer's disease by just 5 years, that's just 5 years, the numbers of people that won't be affected, over 6 million people, or nearly 6 million people by 2050, won't develop the disease. Not to mention the families and our society that won't be affected by this increased number of individuals. That's incredible and that's significant. Today, there are over 200 clinical trials that are going on that are addressing different aspects of the disease, different underlying biological changes that are happening in an individual with Alzheimer's. And they're also looking at people across that continuum, both individuals with preclinical, so those earlier changes before an individual has the memory changes, but also looking to help people in the more advanced stages with memory that are already experiencing the more severe memory changes. But there's also quite a bit of work going on about the impact of lifestyle and behavior, and what might be things that we can do today to keep our brains as healthy as we can as we age. So while we don't know the cause of Alzheimer's disease, there are some hints that science and literature tell us may be linked to increasing an individual's risk or decreasing an individual's risk in later life for developing Alzheimer's disease or cognitive decline. So when we look at the data around cognitive decline, so this is as we age, the changes that we have in our memory and our thinking our thinking and reasoning, there's strong evidence to suggest that there are behaviors that could increase our risk, such as current smoking, having midlife hypertension, midlife obesity. And those are things that we can address today to help adjust our risk in later life. This data or this information actually came from an evaluation that the Alzheimer's Association did of the state of the science to say, really, what can we say today about what may increase or decrease our risk in later life? And this was further confirmed by a recent study that came out this past summer at the Alzheimer's Association's International Conference by the Lancet Commission on Dementia, where it underscored that about 35% of global dementia may be preventable by looking at lifestyle factors and behaviors. And this is across the life course. So thinking about early life, education to age 15, midlife, again, we see hypertension and obesity, but also midlife hearing loss, and aspects of later life that may also contribute to our risk overall, that if we interceded in these behaviors, such as smoking or physical inactivity, that may benefit later life risk for dementia. In 2004, there was a large study that came out of Finland, and it was the first study, what we call a randomized control study, which is really the gold standard of any intervention, whether you're testing a drug or a lifestyle intervention. They had about 1,200 individuals, half which received a very specific lifestyle recipe and half that didn't. This combined nutritional guidance, physical exercise, memory or cognitive stimulation, social interaction, and management of cardiovascular risk factors. And what they found was that individuals that engaged in this lifestyle recipe had decreased cognitive decline. So their cognitive health was benefited by engaging in this particular lifestyle recipe. But in Finland, this is a fairly homogeneous population of individuals. And so the big question is, can this be replicated in a diverse society such as we have here in the United States? The Alzheimer's Association is very proud of the fact to be leading a $20 million study to test just this question and try to get us just that information of how much and what do I have to do to keep my brain as healthy as I can as I age. This is a 2-year innovation study that is evaluating a lifestyle recipe. So the idea of looking at physical exercise, nutritional counseling, cognitive and social stimulation, and then improved self-management of an individual's health status with a focus on cardiovascular health, so our overall heart health, our blood pressure, our cholesterol, that type of information. And asking the question is, does this prevent or delay cognitive decline? We also want to make sure that this is in the community so that if successful, it's able to be implemented and utilized quickly by individuals all across this country. Because when we think about these biological changes, whether it's the plaques, the tangles, brain cell death, and how our behaviors may influence that, we also need to think about what this might mean for the individual during, whether they're preclinical, whether they have MCI or Alzheimer's dementia, because the biology does impact an individual's behavior. And so thinking about this continuum is, what are the most appropriate strategies? What is the best tools to support an individual across that entire continuum of the disease, as well as supporting their partner or their caregiver throughout that duration? I'm going to pass it to Joanne.
Thank you, Heather. So as you heard from Heather, our organization was built on the mission of research, brain health, and care. And the burden to provide care to all who need it is an imperative that we acutely feel for 2 main reasons. One, because the burden is great. We and other service organizations are not reaching enough individuals. Too many people are not receiving support or service that could improve their quality of life. And 2, organizations who are caring for individuals with Alzheimer's and dementia need evidence-based guidance that is practical and applicable in multiple settings. Heather, if you can go to the next screen. In order to reach more individuals to improve overall quality of life for caregivers and those living with the disease, there needs to be innovation on both sides of service delivery. individual services, and how organizations can provide dementia-capable care. In its simplest terms, we often refer to it as one-to-one approaches and one-to-many approaches. There has been a significant amount of history in innovating programs of work in individual care, but less research on organizational or system-level impacts for improving quality of life. Next slide. So Dr. Snyder talked a little about the numbers of individuals impacted. On this slide, it goes into a little more depth on the emotional and quality of life burden that is associated with the disease. The fact is, the disease duration plus the loss of cognitive skills over time equals a significant amount of caregiver stress. Caregivers provide help with all activities of daily living. 70% of people living with Alzheimer's reside in the community, usually with family caregivers. Ultimately, the health of caregivers is suffering too. The numbers are also a demonstration of the need to find methods to provide care and support services in ways that are meaningful and relevant to the individual who needs them most. Next slide. I would like to highlight briefly what is on the slide, but also what is not on the slide. Many of our association's local services are made possible through philanthropic relationships, inclusive of programs being offered in communities nationwide through our greater than 70 chapters. As for what is not on the slide, we all have one key opportunity in front of us. Historically, evidence-based interventions for in-person support are time-intensive. In order to have meaningful improvements in quality of life, individuals have to commit time resources that are not possible for the majority of people. So as we look at innovations for individuals, it has to include improving quality of life in novel delivery modes or with less time pressure. And these modalities need to be created through research that has broad dissemination at the forefront. Next slide. One delivery model that has the potential to change immediate quality of life is reactive helpline support. So while I won't read all of the bullets to you, currently our Alzheimer's Association free of charge helpline service does provide reactive care and support, information, and referral. However, we believe that it also has the potential to be expanded to build an evidence base for phone-based interventions beyond just reactive support. Building an intervention model that has fewer barriers, a broader evidence-based application, potentially provides us and other organizations the ability to reach more individuals where they are with the support and service they need. Next slide. Thank you. I would be remiss to not mention the suite of online programs available. Online modalities provide a lighter touch but should not be ignored for ease of accessibility. There are 5 main pages that I would highlight as key resources for providing help. Our Alzheimer's Navigator online, which is online care consultations, All's Connected, an online community for peer support. I Have Alzheimer's, which is a page designed by and for individuals living with Alzheimer's. And the Caregiver Center that has tips, strategies, and resources for help at every stage of the disease, including personal care, medical care, safety issues, care options, legal and financial planning. Also, our Community Resource Finder, which is a database of community services, including residential facilities, home health, elder care attorneys, adult day centers, and geriatric care managers. On the next slide, we begin to think about how can we begin to influence organizations. So as we think about the next step of providing improvements in quality of life, we need to consider how do we innovate to influence how others or organizations provide care to individuals living with this disease when we cannot be the direct care provider. As an important voice in person-centered care, the Alzheimer's Association is updating the dementia care practice recommendations to influence how care is provided in long-term care and through community-based providers. Next slide. As a quick history in dementia quality care, there have been several publications over the years. Our guidelines for dignity, key elements of dementia care, all of which have a person-centered focus and were published with the latest evidence at the time. As the association and experts in dementia care reviewed the necessary revisions for the dementia care practice recommendations, the expert group really reviewed feedback on the format and structure, conducted focus groups with care experts, and looked at a thematic analysis of existing dementia care guidelines. Next slide. With the intent of putting person-centered care as the main focus, the practice recommendations focus on all areas shown within this picture. And I recognize it might be a little fuzzy for you, so I'm going to just go ahead and read them out to you. It's detection and diagnosis, assessment and care planning, medical management, information, education, and support, ongoing care, staffing, therapeutic environment and safety, transitions and coordination of services. Each of these bubbles represents a topic area within the practice recommendations and have a focused article on the topic. There are 9 topic areas in total, inclusive of a literature review, best practices, and high-level recommendations. If you can click one more time for me, Heather, what you'll see is these updated practice recommendations will be published in a special issue of the Gerontologist in February of 2018, and actually will be available online in January. Next slide. I'm going to pause just for a second and let you read through this. But each article's authors are experts in their fields. Many are probably familiar to you for their contributions to the field in person-centered care or the provision of care. Each of these was on one of those bubbles on the previous page and will have its own article within that Gerontologist special edition. Next slide. In addition to the scientific articles that are being published, we're also looking at a supplemental piece. Each of these bullets, I'm not going to read through, but it represents an incredibly important view in the dementia care practice recommendations. In addition to those evidence-based articles published in the Gerontologist, we also asked people with the disease what good care means through a survey with our early stage advisors. This resulting piece will be published as a supplement to the practice recommendations as a non-scientific companion piece. However, the important viewpoint gives a personal voice to the person-centered philosophy and the imperative of including individuals with the disease's experience in the building and understanding of care services. Next slide. Ultimately, the publication is an important step in advancing the evidence. However, we need to also understand the path to changing provider behavior as well. As we look at general dissemination strategies through conference presentations and exhibits, we also have to consider the steps to create readiness for organizations to be informed, become ready, and also take action to provide care based on the practice recommendations. Ultimately, this is not about what we do, but instead the influence all of us can have to ensure organizations and care providers at the community level are meeting standards of care developed by experts and ultimately improve quality of life through organization-level interventions. This strategy moves us beyond just publishing and hoping that someone will pick up our guidelines. This moves us into publishing and implementing the ability to change how practice is delivered locally. Next slide. Lastly, thank you for all you do to improve the hope we have for a cure and the help we can provide to individuals in need and the providers who care for them. We would like to thank Grantmakers and Aging for this opportunity to talk with you this afternoon. We're equally appreciative of the session's sponsors, the John A. Hartford Foundation and Bader Philanthropies. Bader Philanthropies has been a longtime supporter of the Alzheimer's Association and a member of our organization's Zenith Society, our highest and most involved level of philanthropy at the association. And thanks to all of you for participating this afternoon. John, I think we would be happy to take any questions at this time.
All right, thank you so much. To remind our audience, you can enter your questions in the question box that's on your control panel on your screen. You just open that box and type your questions in, but we have some to start with. So in some ways, and I think I'll start this question to Dr. Pike. So in some ways, some of the issues that you talk about are basic, you know, the basic healthcare recommendations. Stop smoking, work on diabetes, exercise more, and so on. Are there some that are more specific to dementia? And if so, which ones would they be?
Are you in particular thinking what we would recommend for a provider to look to change about the person that they are caring for?
Yeah.
Or just behaviors
so
overall?
Well, yeah, if you're, well, either a medical practitioner or if somebody themselves was trying to figure out how to do better Many of these are recommendations across the board for healthcare. Are there any that are more specific to dementia?
Yeah, and I would also invite Heather to chime in too on this. But I think the biggest piece that we think is an underutilized benefit from the perspective of individuals who are going into a provider, and also a benefit that the provider could be using themselves, is the simple view into asking questions about someone's cognitive impairment and using the tools and resources that are available to them through Medicare to really assess where someone is. And it also could give voice to someone who does have questions about what they are experiencing. There is also a new benefit that came out as a temporary benefit last year, but will become permanent next year, which is a care planning benefit through Medicare, that once someone is diagnosed with the disease, they will have access to care planning. That is a long-term process that includes looking at what resources they need, what can the physician's office provide, and referrals that are available in the community for them moving forward. Heather, is there anything you would add from the prevention side, or what you're looking at from Pointer as well?
Yeah, no, thank you, Joanne. In terms of behaviors that we see the strongest evidence around today that are linked to reduced risk in dementia, physical activity, so being as physically active as you can be, that's probably the strongest evidence today, but we don't know, there's a lot of aspects that we don't know in terms of the duration, when you need to start, all of those types of things. It does seem to be consistent that it's beneficial whenever you start, just the level of benefit seems to be different across individuals. And the other thing I would really underscore, and I may not have done this, is that it doesn't seem to be that one thing is more beneficial. I mean, the strongest evidence is around physical activity, but actually what the evidence suggests is it's really combining all of those things together. The Alzheimer's Association has the 10 ways to love your brain, which really puts together those 10 behaviors. So, be physically active, manage your numbers, continuing to keep your brain active, use it or lose it, stay socially active, wear a helmet if you're riding a bike, wear your seatbelt in a car, those types of behaviors. And it's really doing all of them together in combination that seems to be the most beneficial long-term for cognitive decline and possibly for dementia.
Well, thank you very much for that. You talked a little bit about the program that you have initiated around providing services anywhere someone is. And as you may know, Grantmakers and Aging is deeply involved in rural care, so care for people who live in rural areas where very often even the traditional caregiver support groups and so forth are very hard to come by. Do you see this as a major mechanism to reach out to rural areas?
Thank you for asking that. I think there's two sides to rural outreach that really deserve and warrant some attention, and where we've been thinking about future opportunities, certainly. As you mentioned, the people who need the support need to think about modalities where they're not, when they're not capable of driving 60, 80 miles to a support group. So what can we be doing to bring the support group to them, or the services they need, whether that's a care consultation or a long-term proactive engagement with them that does use either web-based or phone-based technologies, almost like a telemedicine type scenario. But also where there are providers, healthcare providers and dementia care providers or paid providers within the rural setting, what can we be doing to enhance their skill set so that they're providing the best care possible to people living with the disease and their caregivers? So we've also been looking at methods of cohort or long-term learning for those types of primary care that are in the rural setting, or those dementia care providers who may need some additional support. So how does technology impact our ability to teach and reach other individuals who are providing care when we are not the direct provider ourselves?
Thank you for that. A question now about another one of the factors that you list, which is sleep hygiene. So could you say a little bit more about what that is and how you see that role moving forward? Is this sleep apnea, or is it a broader concept than that? So if you could explain that a little more.
Sure. So this is Heather. There's been a growing number of studies that have looked at sleep disruption. So that can include sleep apnea as a part of that. Disruptive sleep, so individuals that may not sleep for long periods of time, the duration of sleep. So it's really all of those different factors that come under that more broad umbrella of sleep disruption that seem to be linked to brain health in later life. So there haven't been studies, there's only been one study to date that's actually tested an intervention for sleep or disruptive sleep and seen that there was a benefit. It was a very small study, but there are, certainly an active area of investigation to try to understand the biology, the underlying biology of how sleep might be related to risk or what it might be doing for our overall brain health. For instance, when we go to sleep, our body or our brain actually uses that time as a kind of a clearance mechanism for taking out the trash, if you will, and to clear out things that have accumulated during the day. And so when sleep is disruptive or there's issues with sleep, that could impact that biology, that underlying mechanism. And so the thought is that if we can prevent the sleep disruption, can we benefit in later life? We don't know that answer, but trying to understand those connections is certainly an active area of research. And making sure we get a good night's sleep is, or as good a night's sleep as we can as we age, is also something that is encouraged for brain health overall.
This is a general question for either one of you. How well do you think we are training the healthcare workforce in this country to recognize and to do the kinds of early intervention things that you're talking about? Is it the case that most physicians would know to screen for Alzheimer's? Is it something that you recommend doing at a certain age? But in general, the question is, how well do you think we're training people that are actually providing care for most Americans?
So this is Joanne. I will start that, and Heather, if you want to add anything in, let me know. But we've been doing some significant research in this area. In particular, we've started looking at some market research to understand what is the training needs, the education needs, but also what is the confidence level of our providers to be able to diagnose, treat, and feel like they can have a positive impact for those living with the disease. And I would say I think this is a huge opportunity for us. I don't think we're there yet. I think there's a significant amount of opportunity. And in fact, I just saw an article come across my desk that talked about the fact that we do not have a healthcare system infrastructure that's prepared for Alzheimer's treatment. And I think it's indicative of a few things. We have the opportunity for ongoing continuing education and support, but also in a place where we have a disease where we don't have a disease-modifying treatment. We need to provide the understanding that healthcare providers have an important role in making sure that quality of life issues are addressed until we do have a day where there is a treatment available. So ultimately, there is significant opportunity to make sure our providers are prepared to do this moving forward.
Yeah, and this is Heather. I would just add a few things. So at this past summer's AAIC conference, we actually saw a report out of that across this country that we have neurology deserts, is what they're calling them, where we really need to have those specialists that are trained to help and support people with dementia. And that's something that the Alzheimer's Association has been keenly aware of, and actually has been investing. One of our funding programs is to train the next generation of clinician scientists to be just that, to prepare them for that workforce going forward. The recent study, or the recent paper that Dr. Pike mentioned, was really based on a model that had a number of different assumptions that it put into place, but what it does do is it really underscores the importance that we need to be prepared for when there is that disease-modifying treatment. When we have that way to stop or slow the progression of the disease, what we need to put in place. We need to have the experts that are trained and ready and able to identify the early warning signs so that we can intervene at that earliest time point to stop or slow the progression of the disease. But even today, without that, there's still a lot of benefits for early detection and diagnosis. There's an opportunity for an individual to make decisions about their own care future, their financial future, participate in a clinical trial that can potentially change the course of the disease, have that conversation with their family. There's lots of opportunities for that person with the early diagnosis to get involved and to be engaged. And, I think even without that disease-modifying treatment of the tomorrows, we know that there's a huge benefit for individuals today as well.
We're going to stick with that theme. We have another question that just came in, and I'm going to add a little one to this one. A couple of years ago in your annual review of evidence, the Alzheimer's Association did an investigation of how often providers shared dementia diagnoses that had been recorded in the charts with patients and families. The shocking finding was that in many cases, there was documentation in the chart that didn't seem to have been shared. Does this result still hold up? How's it gotten better? I will add in my own family's case, my mother is living with the disease. And the good news was her family practitioner out in rural Texas started doing sort of baseline work with her sort of long before she started to have major symptoms. And he did this every year as part of her checkup and never shared the information with her or with us until she became diagnosed with Alzheimer's in a more formal way. So are you seeing this getting better, or is this something we have to train people to do more rigorously?
So this is Heather, and I can just chime in a little, and then Joanne can add. I think that was a kind of a focus report where we really did an evaluation of the numbers and where it was. It was, I think, just 2 years ago, and so there hasn't been an update of that particular number. But I do think we're underscored by stories like your story is somewhat unique, John, in terms of I think we hear other stories about that information not being shared and passed on. I have people say to me all the time, "Oh, my mother had dementia. Thank goodness she didn't have Alzheimer's," because just the terms and not knowing that Alzheimer's is a type of dementia, and actually the most common cause for dementia is I think there's still a lot of confusion and misconception about those different terms. One of the things that the association's been doing in the last few years is really underscoring and looking to provide those education opportunities and share information and have really inform the public and the society about these causes or about these differences and about the needs, that when you have questions to go speak to your healthcare provider and make sure you ask the questions too as to whether they feel comfortable having that conversation with you, and if they aren't, find someone that is. And the Alzheimer's Association, we provide care and support for those that are affected, but we're also a resource for those that have questions about anything. So that's something that people can always call us. Our helpline and our website I think are on the screen right now as well, to help give people direction as to a specialist that they can, or somebody that has the expertise in dementia questions and diagnosis that they can connect with in their community. The other thing that we have is the 10 warning signs. So that's really the 10 things that you should be looking for, and really raising awareness around what those are. And it's not one or another so much as it's anything that's going to change in your behavior over time, to make sure that we're expecting that from the healthcare professionals, but that we're also asking those questions as well and raising that up as a priority in our society.
Well, thanks. I think we've only got time for a couple more questions, but let me ask you a question now about more on the caregiver side. So as we know, the baby boomers are turning 65 at the rate of 10,000 a day, and that's right now the driver of the increase in the number of older people. Of course, that's a tremendous wonderful thing to this happen to us, that we have longer life. But as you know, and as if you pointed out, the dementia can follow with that. I think the other thing that we sometimes do not recognize as much with boomers is that they are much more likely to have never married or have children, and therefore to live alone. So are there initiatives that you're undertaking to really try to get at that aspect, that there'll be more and more people with dementia and with Alzheimer's who are not going to have anyone to have as a natural caregiver for them?
And this is one area that we have looked at across the country in various ways. And certainly many of our local specific activities have been funded by some of the local philanthropies around our Live Alone outreach work. And certainly we know that there are some very specific challenges when aging alone. And so we do provide a significant amount of support from the standpoint of what we can provide from our online resources, our helpline, and then that local programming that has been funded. We in particular recognize that area of work is somewhat geographic bound in a few areas because there are certain areas of the country that have higher aging populations by themselves than others. In particular, we've done some diversity-based outreach with our LGBT, our lesbian, gay, bisexual, transgender population around that Live Alone initiative, along with our outreach with SAGE, to really look at how can we provide care networks and support groups for our early stage individuals and build the resources in a community around them.
Thank you. I think we have time for just one more. So this is a question about the risk of hospitalization for those with dementia, and that the understanding that there's more of a likelihood that people with dementia will be hospitalized either because they don't have, they can't take care of themselves in the same regard, or something as an emergency happens to them. Is this a powerful reason for the diagnosis, even if there isn't a treatment for Alzheimer's at this point that's going to cure the disease or make it substantially less? And I think this gets at a broader issue, which is, I sometimes hear from people, including from people in my own family, there's nothing we can do about it anyway. So we're just trying our best to make the person, comfortable. How do you talk about that and helping people to see that there are things that can be done and should be done to improve the situation, even with someone who is going to be facing this very difficult condition?
Yeah, it's a great question. I think Heather and I both touched on this a little bit, which is knowing where you are with the disease and with dementia is an important piece to understanding how can you make decisions today and improve your quality of life long term with being able to make some of those choices and decisions with your family or with your care partners that will impact the progression long term. It also gives you a chance to build a network of where you want to be, and the decisions that you could make around either aging in place in your family and what the resources are that are necessary. So while we wouldn't necessarily encourage, I shouldn't say necessarily, we wouldn't encourage people to view a fatalistic approach to where they are, but instead enjoy the moment and be able to make some of those decisions today that are going to impact where they could be tomorrow, because there is a significant amount of quality of life decisions that we can influence for the long-term care.
Yeah, and I think just to add into that, there is absolutely that importance component that if, for instance, you have Alzheimer's and diabetes, to help manage the insulin treatment or whatever your medication therapy might be to prevent a hospitalization, and having awareness of that would allow you to put those types of things in place as well. So, again, to underscore the importance of early detection and diagnosis, even in the absence of having a treatment that will stop or slow the progression of the disease, is incredibly valuable to the individual that's living with Alzheimer's or related dementia.
One other thing I would add is I mentioned the dementia care practice recommendations and really being able to look at in the future how are organizations caring for individuals in the community and using those practice recommendations to really provide a base of person-centered care and using that to make some choices for family members in the future as well is going to be very important.
Well, thank you so much. At this point, I'm going to ask each of our distinguished speakers today to wrap it up with their final words of wisdom. Heather, why don't we start with you?
Absolutely. I think, well, thank you very much to all of you for being here today and for your time, and to Grantmakers and Aging for this opportunity. I think the one really key thing that I want to always share with audiences is you're not alone. That there are, again, over 5 million Americans that are living with this disease, the more than 15 million caregivers, and the Alzheimer's Association is here for you. We're in communities all across the country. We know that people that access resources or that and understand what's happening to their family member or their partner or their friend have better outcomes overall, both for the care of the individual as well as for themselves in terms of a whole slew of outcome measures. So you're not alone, and reach out for support and services if you are in the journey with Alzheimer's or related dementia.
Joanne?
I don't think I could add much more than what Heather just beautifully said, but the one thing I would add is as we're looking at really building much broader reach within our program portfolio, and as each of you have a significant amount of influence within that in your own communities, think about the numbers that could potentially be impacted and the dissemination potential as you're looking at programs of work. Many things that are an opportunity can be built in ways that go beyond the one community that is being impacted, and being able to move that in a broader way is important, especially as we think about reaching more individuals in the future.
I want to thank Dr. Heather Snyder and Dr. Joanne Pike of the Alzheimer's Association for their wonderful presentations today. We thank you and all of your colleagues at the Alzheimer's Association for all you do to make life better for older adults and people of all ages. I also want to thank Bader Philanthropies and the John A. Hartford Foundation for their support of this webinar today. We will be making this presentation available to anyone who wishes to view it later, including the slides and the audio. Just watch for a rebroadcast link on our website or contact Grantmakers and Aging. And we want to particularly alert you to a couple outstanding webinars that are coming up. On Tuesday, November 28th at noon Eastern, so that's a different time for us, please join us for a special webinar with Dr. Kedar Mate and his team at the Institute for Healthcare Improvement, who will be sharing information about the Playbook, which is a collection of evidence-based resources for health system leaders, payers, policymakers, and others seeking to learn more about promising care approaches for people with complex health and social needs. And then on Friday, December the 1st at 2 p.m., which is our regular time, we will be joined by the new administrator for the Administration for Community Living and the HHS Assistant Secretary on Aging, Lance Robertson. This will be Administrator Robinson's one of his first opportunities to present to a national audience. And so we're very excited to have him on, and you will have an opportunity to ask questions at that as well. So that's December 1st at 2 o'clock. All of this will be on our website, and you'll receive a notification. So, and we want to thank our speakers once again, and all of you for participating. So thank you today for participating in today's webinar, and have a great day.